Okay. Thanks.
Okay, I think we're ready to kick off our first webinar. My name is Joe Farrell. I'm a survivor of sudden cardiac arrest. I also rescued 2 people with CPR and AED use in my sudden cardiac arrest life. I'm the vice chair of the Sudden Cardiac Arrest Foundation and one of the co-chairs of CASA with Alex and Mary. We're very honored to have you all part of our community and participating in our first webinar, where hopefully we'll publish within the next week or two a programs for a monthly webinar. So we'll have a lot of active webinars. And as we proceed this afternoon, we'll have time for questions and answers at the end. So I'm going to turn this over to Mary, Sudden Cardiac Arrest Foundation President and CEO, to introduce our keynote speaker. Thank you, Mary.
Okay. Hi, everybody, and welcome. We're so happy you're here today. I wanted to introduce Alex. Alex Prescuitti is a clinical psychology fellow at Massachusetts General Hospital and Harvard Medical School. At MGH/HMS, he is developing interventions for cardiac arrest survivors, family members, and others impacted by critical illness. Clinically, he sees both inpatients and outpatients through the Department of Psychiatry. Prior to MGH/HMS, he earned his MA, this is a little alphabet soup, sorry, in clinical psychology at Columbia University, and he completed an NIH research fellowship at the University of Colorado, where he earned an MS in clinical science. Alex is on track to being awarded his PhD in clinical psychology from the University of Colorado in August 2023. Alex has spent the last 8 years dedicated to improving quality of life and emotional well-being in all those impacted by cardiac arrest and critical illness through research and service. To date, he has published 21 peer-reviewed articles on these topics, has given numerous national and local talks, and actively collaborates with the Sudden Cardiac Arrest Foundation. Together with SCAF, he helped launch the Cardiac Arrest Survivor Alliance. Take it away, Alex.
Thank you, Mary, and thank you all for having me. For folks that joined a little bit early, I will be manning the waiting room, so I might pause at times just to make sure we're letting everybody in. But with that being said, happy to kick off this first webinar, talking to you all about emotional well-being and ways to cope after cardiac arrest. So just some acknowledgements, as Mary noted, most, if not all, of this research wouldn't have been possible if it wasn't for the Sudden Cardiac Arrest Foundation leadership, as well as the members who took part in the research. And then similarly, as mentioned by Mary, a lot of this research was funded through the NIH. So some objectives for today, obviously, I want to provide an overview of some of the research that we've been doing on distress and coping post-arrest. Hopefully, this talk will also provide some insight into existing concerns that folks may already have. And then I really just want to make time for some fruitful discussion with you all, being mindful to not discuss specific cases or case studies, but rather have a general conversation about what to expect post-arrest and, general ways to cope. So just an overview or an outline. We're going to start with common cardiac arrest survivorship challenges that many of you all know very well. We're going to talk about specifically the impact that emotional distress can have on us after cardiac arrest. And then we'll end with coping and open up for discussion. So some of you may, or if all of you may know, cardiac arrest survivorship is complex, right? Our heart stops and the brain is deprived of oxygen. That's what can explain a lot of the thinking changes that happen after cardiac arrest. And in my experience, particularly in the beginning of my career, I was so surprised with how many survivors and co-survivors I was meeting that didn't know the link between the brain and the heart in this event. And so I was in the awkward position as a research assistant telling people for the first time that, yeah, your heart stopped, your brain was suffering. And so that's why you're having memory problems. But it's not just the brain stuff. So there's also physical symptoms. Some folks experience movement problems, fatigue, other symptoms that impact, functional independence. And then, of course, the emotional distress that we're all here to talk about today. And so historically, there's quite a few reasons why, survivors and co-survivors experience distress, some of which have to do with larger systems in place. Others have to do with, the brain stopping and having this sudden confrontation with death. Starting with the systems. So historically for hospitals, it was a success, to discharge people alive. If you were discharged alive, you were given a pat on the back and your care kind of stopped there. And so because of that, providers really had little awareness about what people actually experience in the long term after cardiac arrest. And so intuitively makes sense that there's really no standardized way to offer support or resources because providers really just didn't know. And you can really contrast this with other conditions that maybe historically have a larger survivorship base, may it be heart attack, stroke, or cancer. With that being said, rates of survival have steadily improved, particularly in the last 30, 20 years. And so with that, there is a growing survivorship base. And so we can do research and really understand what people experience. See, up to now, without these resources for survivors, the cognitive changes, the physical changes, the emotional problems are going to linger. And if folks aren't directed to who they should seek their follow-up care for, these problems are going to go on unaddressed. And typically, if a survivor is experiencing thinking changes at the time of discharge, it's really the caregivers who assume the bulk of the burden. And again, the caregivers don't have a direction because historically the providers didn't have direction. Other sources from within that can contribute to distress are what I call, or what the field is starting to call, enduring somatic threats. And these are basically recurring bodily reminders of the heart event. This idea of enduring somatic threats came from the heart attack and ACS literature, but some of the work we've been doing, we've been finding that this is pretty applicable also to cardiac arrest survivors. So whether it be the sensation of your ICD, sensation of an ICD shock, fatigue, weakness, changes in heart rate, really anything that reminds you of your cardiac arrest that starts from within can sometimes serve as a traumatic reminder of what the survivor had gone through. So an overview of what I've talked about so far. Hopefully most of this is not new to you all, although I wouldn't be surprised if this is the first time that some of you are hearing these things because of this historical kind of the situation that we've been in so far. But just to summarize, cardiac arrest is both a heart and brain problem. It can lead to cognitive, physical, and emotional challenges. And up to now, there really hasn't been a standardized approach to providing resources, neither for the caregivers or the survivors. And so as a result, the post-cardiac arrest symptoms linger, which includes, the emotional distress. So now we'll kind of pivot and go from the broad to the specific, talking about emotional distress specifically after cardiac arrest. And, I've been privileged to be in a position where I could do research, what's called qualitative research, where I could actually interview folks and extract quotes like some of the ones that I'm going to present now. And I've done quantitative research where I've been able to measure things like anxiety and depression and quality of life. So what you're going to see in the following slides is a little bit of integration between the qualitative and quantitative. So this first quote, I think, is truly representative of many people's experience post-cardiac arrest. I had no expectation that any of this stuff would be as difficult as it has been. I lost a lot of drive and a lot of the ambition that I had, and I just sort of exist. It was very difficult to all of a sudden be hit with a feeling or an emotion that seemed out of place, Everything would be going fine. And then all of a sudden you'd have this feeling of impending doom or dread for no reason. So in the past 8 years or so, I've been involved in collecting what's called observational data, asking folks how they feel, having measurements to actually quantify the degree of the symptoms. And a lot of this work I've done with the Sudden Cardiac Arrest Foundation. So in a group of about 160 or so folks that were on average 5 years post-event, about 1 in 3 survivors had a positive anxiety, depression, or post-traumatic stress disorder screen. No surprise. What is surprising maybe to our other medical colleagues is that also 1 in 3 caregivers had positive anxiety, depression, or PTSD. Now, for everybody on this call, that may not be surprising because you guys have lived it. But for providers who, as I said up to now, have not been following survivors in the long term, they don't know what the survivor caregiver pair goes through. Again, it's those caregivers that witness and remember the arrest. They remember the rescue interventions and the uncertain, lengthy prognostication period. And so other than the fact that emotional distress in itself is problematic, it also has other downstream impacts. So in some of the work we've done, we've found that emotional distress is linked to worse quality of life, again, in both survivors and caregivers. And this is beyond memory problems and functional dependence. In other words, the quantifiable relationship, if I may, is stronger. The quantifiable relationship between emotional distress and quality of life is stronger than that of memory problems and functional dependence. More so when you directly ask folks if they feel like they've made a full recovery from cardiac arrest, it's the emotional distress, not the cognitive changes or functional dependence, that are the strongest predictors of how they respond. In other words, if I have high depression, high cognitive changes, and I'm really not functionally dependent, it's going to be the emotional distress that explains how I'm going to respond. It's going to explain the fact that I'm going to respond negatively. Even when cognitive impairment and functional dependence aren't present, it's still the emotional distress that's going to predict how folks respond. And we found this relationship both at discharge, so when we ask folks at discharge, but also 6 months later. So what we're finding is a theme, right? It's not discounting the fact that the cognitive and the physical is very important to the recovery experience. But it seems like this emotional distress might be an even bigger issue that folks encounter. What's more is, a big driver of distress is likely this idea of lacking resources. So among we did within this big survey that we did with the Sudden Cardiac Arrest Foundation, almost 75% of folks reported experiencing emotional distress after their event, and 67% reported experiencing cognitive changes. So the overwhelming majority. Despite this need, only about a third, less than a third really, had discussions with their doctors about the potential for experiencing cognitive changes, and even less, about 25%, had conversations about potentially experiencing emotional distress. So when 73% of people are experiencing emotional distress and only 25% actually have conversations about it, there's a problem. There's about 50% of people or so that are never having this discussion. When it comes down to actual resources, actual appointments being scheduled, only about 8% reported having a neurologist appointment scheduled, less than 5% had a psychologist appointment scheduled, and about 6% had referral to any mental health at discharge. Now, I know there's probably folks in our virtual audience saying, well, how could this information could be biased? Survivors with cognitive changes may not remember, and that's true. So we did the same analyses with the caregivers, and there was what's called a non-significant difference, meaning that basically the results were the same. Another representative quote: none of the providers offered any solutions, treatments, therapies, or any way that I could receive treatment and improve. Oops. So what we're finding obviously is the communication, and particularly the communication early on with our providers, matters. It can really dictate the course of our recovery. It can dictate which services we follow up with after we leave the hospital. So unsurprisingly, when survivors reported having a low quality interactions with their providers, be it lack of information or what's called being threatened by their illness based on how the information is presented, these factors are linked to more emotional distress and worse quality of life post cardiac arrest. Again, all of this stuff may be no surprise to you guys. This is a big surprise to a community to a academic / research community that up to now has not been following folks like you. I think it would have helped me an awful lot if I had more of an explanation about what was actually wrong with me. How often has something like this already come up in our forum on CASA, and it's only been up for about a month? All right, so a summary of what we've talked about so far. Emotional distress is prevalent after cardiac arrest, both in survivors and caregivers, and it's also problematic. It impacts our quality of life and how we perceive our recovery after cardiac arrest. We know that survivors and caregivers receive few resources, so as a result, they're kind of lost without direction. They don't know which follow-up care to seek out, and this is a major problem. So enough of the bad. A lot of everyone that's here knows about the bad. Let's pivot and talk about the good. What can we do now? So my research, both my research and the wider community is now pivoting from this observational research that I talked to you all about, asking people how they feel, measuring it with symptom severity measures, to now developing interventions. And the first one of the approaches to developing interventions is specifically identifying the targets. What are things that we can teach or train people to do to cope with cardiac arrest? And so one that really stands out, both in clinical psychology in general, but particularly something that could be positive in cardiac arrest, is mindfulness. Now, this is a term that's used a lot now in popular culture, and there's many different definitions. The definition I like is purposeful awareness of the present moment. It takes away all of the mystery takes away all of the mystery from this term and really makes it concrete. It's being in the here and now. Mindfulness can be practiced informally or formally. What I mean by that is you can be mindful. You can be fully present when you're eating, smelling the smell of your food, the taste of the food, being present in conversation, listening to everything that your conversation partner is talking to you. When you go visit the Grand Canyon, it's taking it all in, focusing on your sense of sight. That's what I mean by informally practicing mindfulness. Mindfulness can also be practiced formally through meditation. And so the mechanism and why this is can be particularly helpful after cardiac arrest is that it recenters us from ruminating about the past, maybe our past functional abilities, as well as recenters us from future anxieties. Am I going to have another event? Is my loved one going to have another event? From our interviews with survivors, there's one thing that seems to be very prominent after cardiac arrest is this fear of recurrence, ruminating over the sudden losses in physical and cognitive abilities. And so something like mindfulness those thoughts are still going to come up, but when we practice mindfulness, and we do it consistently, we can more often return to the present moment. Another nice thing with mindfulness as a potential intervention target is that it's teachable. Yes, one can have more of an inclination to being mindful, and it's something that can be trained and consistently improved over time. And so unsurprisingly, in a follow-up study with our survivorship community, we found that greater mindfulness practice was linked to less emotional distress and less enduring somatic threats. Again, those recurring bodily reminders that I talked about in the beginning of today. So this is great, but mindfulness is just one thing, and maybe I've tried meditation in the past and it really wasn't for me. So what else can I do? It's a good question. So as I said in the beginning of today, we did 15 qualitative interviews with cardiac arrest survivors. really asking them, like, how can we improve survivorship? What can the individual do? What can we change at a systematic level? And what we came away with were a lot of good recommendations. Not only did long-term survivors give us their ways that they coped adaptively, they also talked about how we can improve things at the social and systemic levels. So individually, common themes that came up: acceptance, accepting that the cardiac arrest happened, and by accepting, being able to open ourselves up to moving on, changing maladaptive habits, being more present. Mindfulness, as I already talked about, was often cited. Resilient coping, and that's kind of like a big umbrella term. What does resilient coping mean? So anything that allows you to bounce back from adversity in a way that's adaptive. So what I mean by that is changing maladaptive behaviors, whether it's resorting to substances or practicing avoidance, or anything that keeps you from actualizing a full holistic recovery. Engaging in healthy behaviors to take back control. I want to be very clear here that when I say engaging in healthy behaviors, I'm not a nutritionist and I'm not an MD. So I can't speak about the link between eating well and cardiac arrest, particularly if your cardiac arrest wasn't from underlying cardiac disease. What I can say, though, is that eating well, exercising, and going to sleep going to sleep for 8 hours is going to bring a little bit more of an element of control in our lives. And I can say that these three things are going to impact positively our mood and well-being. So why not give them a try? And then the big one, focusing on meaning and purpose in life. Many folks that I interviewed already had sources of meaning, whether it was their grandkids, building a home for their family. And so they put themselves all in to those sources of meaning and purpose. There was also a lot of people that felt like they had no meaning and purpose before the cardiac arrest, and that the cardiac arrest was a wake-up call to go out and find passions. And so this is why I say focusing on the meaning and purpose, because I know for some folks that may not exist right now. And so I'd encourage you to really try and seek out the things that drive you and that make you feel passionate. Socially, folks talked about, again, this is intuitive, but utilizing social supports. There's a saying at MGH, never worry alone. And I do think that that's something that can be applied post-cardiac arrest. Never worry alone. Utilize your co-survivors. They're in it with you. And then, of course, this is not a surprising finding because I was interviewing folks that are already a part of an online network. But again, engaging in peer support groups. Thank God we have CASA now. So this is a great way to offer peer support to each other. So here's an illustrative quote of a gentleman that really was practicing acceptance in their everyday life. So everyone who has this happen wants to just go back to where they were. And just understanding that it takes time to adjust to the new normal and accepting that there's maybe some limitations physically that are put on you. This gentleman, he was able to accept, he had stopped the fight, stopped fighting the reality that actually occurred, that he had a cardiac arrest. This was a particularly athletic gentleman too. And so being relatively immobile was super new to him, and it's something that he was not comfortable with. But with time, he was able to accept this and start finding other avenues to fully participate in life. I've been doing mindful meditation because I was having trouble sleeping at night, obviously, because the cardiac arrest happened at night. I would do meditation or listen to a meditation or listen to music. I would say beauty beats fear every time. I have a bucket list for the rest of my life. I focus on things that I really thought I might try and accomplish. Oops. They also, almost everybody had the same recommendations for how we can change things at a systemic level. And it was always about providing resources and appropriate expectations early on, informing survivors what they might potentially experience. Everyone's different. Everyone's pre-arrest course is different, and everyone's post-arrest course is different. But just providing some information on things that you could experience down the road based on the observational research that people have been doing up till now. We've got some new data, exciting data that was recently just analyzed in the last month or so. We did a collection of about 110 new cardiac arrest survivors at the University of Pittsburgh. And we gave quantifiable measures both on emotional distress, but also on these constructs that the long-term survivors said helped them. So we actually quantified the relationship between mindfulness and distress. We quantified the relationship between meaning and purpose and distress, resilient coping, using social support. And unsurprisingly, all four of these kind of positive psychology factors, if you may, were associated with less emotional distress. Again, this is after accounting for cognitive ability, functional independence, age, sex, income, and whether you had an arrest in hospital or out of hospital. What I want to point out on this slide, though, is that Pittsburgh is a unicorn. Pittsburgh has a dedicated post-cardiac arrest service, and it's multidisciplinary, and they're involved in the care immediately after someone is admitted to the hospital. So they establish a relationship both with the survivor and the caregiver, particularly the caregiver when the survivor doesn't have good cognitive function, which is the overwhelming majority at the moment of admission. And so really they're involved from care through the beginning, and as people are being discharged, they have a comprehensive battery of asking about different resources that survivors may need when they leave the hospital. So can we adopt the Pittsburgh model nationwide and really globally? Can we show the rest of the country and the world its benefits? The short answer is yes, although in my 8 or so years in research, these things take time. You need to show that the Pittsburgh post-cardiac arrest service can lead to less emotional distress than other centers. Studies like that take a lot of resources, many centers that are on board to measure the same things. It's possible, and I think these studies will be done. In the meantime, we can go back to the individual and talk about ways to develop interventions now so that people can effectively cope with cardiac arrest. And so one of the exciting research that I've been involved with here at MGH and Harvard is an intervention in the neuro ICU. So we're studying patients and caregivers, patients that have experienced a severe acute brain injury and their caregivers. So there's obviously similarities there with cardiac arrest, that you have a brain event. There's differences that make the cardiac arrest experience much more different and worth studying in itself. But before we get to given that this intervention is ongoing, we can learn about some of the ingredients from this intervention to inform an intervention in cardiac arrest. And you'll see some overlaps, right? So this clinical trial at MGH that we call Recovering Together teaches mindfulness already. It teaches effective coping skills, teaches you how to utilize your social support, and starts a conversation on meaning and purpose. What's super unique, though, about this type of intervention is that it's what we call a dyadic intervention. We work with both the patient and the caregiver, and we encourage them to work as a team, practicing these skills together. You have another person with you to hold you accountable. And so this intervention is in year 2.5, 3. It will be completed in the next 2 years. In this time, I'm actively working on adapting this intervention for cardiac arrest, which we're going to call Recovering Together After Cardiac Arrest. And the skill content will be adapted to the cardiac arrest survivors and caregivers' needs, a lot of which we've already learned from the qualitative interviews we've done. We're going to connect these survivor caregiver pairs with resources, including the Sudden Cardiac Arrest Foundation and CASA. And we're going to teach folks about the heart-brain connection that underlies some of the cognitive and physical changes that they may experience. All right, so that was a lot, and we're coming toward the end. So just to summarize, through qualitative and quantitative research, we've been able to identify coping strategies at the individual level that we can start utilizing now: acceptance, mindfulness, resilient coping, meaning and purpose, and utilizing social supports. The next phase of our research is going to be in adapting the Recovering Together intervention for cardiac arrest survivors and caregivers, and hopefully in the next few years, we'll have some exciting new content for you all. I want to give special thanks to some of our collaborators and mentors throughout the bulk of the research that I've presented today. Mary, who's on the call here, my colleague Jonathan Elmer at Pittsburgh, who was instrumental in that last Pittsburgh study I cited, Sarah Perman, who really helped me out during my PhD program and is a fantastic mentor, and my mentor Ana Maria Vanchenu at MGH.